Dr. Saurabh, I can't hear you.
Sorry, I was muted. I forgot to unmute myself.
Sure.
Good morning, everyone. Today we are on 18th of July, 2026. We're here meeting for another important session. I welcome all dignitaries from around the world. It is my pleasure to welcome you all for the CMAAO International Weekly Meeting. Today we are honored to have eminent cardiologist, academician, international respected speaker, and a cardiovascular medicine doctor, Dr. Arun Chopra. He's a highly experienced interventional cardiologist with an expertise in complex coronary and non-coronary intervention, cardiac device implants, and etc. He's an APHRS approved trainer in CRT device implant, has authored with over 100 scientific publications, 10 books, chapters, and several associate editor of Tandon's textbook of Cardiology 2024. In addition, he has a clinical experience. Dr. Chopra has special interest in nutrition and lifestyle modification for prevention and management of cardiovascular disease and obesity. We are talking about dietary management on dyslipidemia, highly practical evidence-based dietary strategies to improve lipid profiles and reduce cardiovascular risk. Dr. Chopra, over to you.
Thank you, Saurabhji. And I will now set up my slides. I hope you can see my slides.
Yes, we can.
Sure, great. So my presentation today is on dietary management of dyslipidemia. So this is a presentation designed primarily for physicians, but as this is a topic of general interest, I'll keep whatever I say simple, though the information will be scientific, but it will be more or less in a form that can be understood by most people. So my subject today is dietary management of dyslipidemia. And in that, I will, in the beginning, bring about the problem in front of you and try to make you understand what are the issues involved, what are not commonly understood, and then outline a dietary pattern which is healthy. So dyslipidemia and ASCVD, as you know, are very strongly correlated. ASCVD accounts for nearly 1/3 of total mortality globally. And India too has experienced a near doubling of CVD mortality in the last 25 years. So there is a recent Lancet analysis which ascribes over half of the global CVD risk to dietary factors. Thus, of the 30 million or so deaths every year, about 20 million or so deaths every year, about 11 million are attributable to diet-associated risk factors. Hence, diet is extremely important issue for our health. So there are two issues which continue to bother us physicians. Indians have among the highest prevalence of coronary artery disease, with a greater risk of STEMI at a younger age, even though our average LDL cholesterol levels are not high. And despite more stringent guidelines and cutoffs for lipid levels, more effective drugs on the shelf, the rates of type 2 diabetes, metabolic syndrome, and atherosclerotic cardiovascular disease like heart attacks and strokes are still rising. So why is this so? So I'll briefly in a couple of slides give you the disease burden in our country. So this is from a recently published review, a 360-degree overview of cardiovascular disease in India, wherein it is concluded that the mean age at the time of the first heart attack is 8 to 10 years younger in the West, in India than in the West at age 53. STEMI or ST elevation myocardial infarction, the most serious type of heart attack, is the most common acute coronary syndrome in India, whereas this is not the case in the West. The rise has been phenomenal. There is a 5 to 7 times rise in the risk of coronary artery disease in the last 50 years in our country, and annual CVD deaths have doubled in the last 3 decades. The mortality of a heart attack, STEMI, in India is among the highest in the world at 8.9%. Furthermore, if we look at the right panel, what we find is that dyslipidemia in India is very common. That means a bad lipid profile is very common. But high LDL, which is normally believed to be the cause of most attacks, is actually uncommon. It is 11%. So most of our patients actually suffer from a high triglyceride or a low HDL level. This is data from a recently published study called the Norrin STEMI Registry. This is from GB Pant Hospital, New Delhi. So what we find is that in 5,000 patients, 1/3 of the patients who had heart attacks were young, 18% were below the age of 35. The mean LDL cholesterol was only 88. So below 100 is actually considered to be a good value. So LDL levels in ACS patients are often so-called normal. And this is not confined to India at all. Even in the United States, this is a large registry published in 2008-9, wherein more than 1 lakh patients had their lipid profiles done when they were admitted to the hospital with coronary artery disease. And even there, the average LDL cholesterol was only 105, and nearly half the patients had LDL below 100, and 18% had LDL below 70. So this is a common phenomena. Of course, Indians have lower calculated LDL levels than the West. So as you can see, Indians on average, when they present with heart attacks, have a normal looking calculated LDL level. And please remember the word calculated, which we can talk about later. So what are we missing here? So what we have been missing so far is diet and metabolic health. So what we have to understand is that though lipids are foundational in the evolution of atherosclerosis and in the occurrence of heart attacks, they are not the only thing. So what we have found evidence is that total macronutrients, carbohydrates, fats, proteins, actually have a neutral effect on all diseases like obesity, diabetes, and cardiovascular diseases. So food choices actually matter more than nutrient ratios. Low fat or low saturated fats have not shown to have any major benefits. In fact, higher fat diets, where fats form approximately 40% of daily calories, actually have been shown to improve outcomes without raising serum cholesterol levels. Thus, our focus should shift from nutrients to overall dietary patterns for our heart health. And in this regard, the two diets which have been shown to have the maximum beneficial effects are the Mediterranean pattern and the DASH diet, which have the strongest evidence for their benefits. So to begin with, we have to understand what is dyslipidemia and what are the types of dyslipidemia. So there is a general belief in the lack of efficacy of dietary intervention in preventing ASCVD. The focus for the last several decades has been on drugs. This is due to a failure in recognizing that there are two types of lipid disorders that differ both in etiology as well as in dietary management. So we have the isolated high LDL cholesterol variety with or without elevated triglycerides, which is what most of our drug therapy and most of our clinical emphasis is based on. But the other is metabolic or atherogenic dyslipidemia. So what we find in population is that isolated very high LDL is actually the minority. Only 1 to 2% of patients have this high LDL. And obviously, this is worsened by high trans fats and high saturated fats in the diet, and restricting these will help in some reduction, but not reaching target levels. And this is the subgroup in which drug therapy like statins and other newer drugs which have come up are extremely important in lowering the risk of cardiovascular disease. On the other hand, the burden of atherogenic risk in the population is due to the so-called atherogenic or metabolic dyslipidemia, which constitutes more than 80 to 90% of the population at risk and is characterized by high triglycerides, low HDL levels, and near normal LDL cholesterol levels, as we just saw in the studies which I presented earlier. So the driver here is actually excess calories in the form of refined processed food, rich in sugar, salt, and fats. And this is where dietary modification can act. So let us look at how atherogenic dyslipidemia develops. So it is basically a key metabolic consequence of caloric surplus. When we consume excessive calories, particularly from refined carbohydrates, this stimulates the liver to produce more VLDL particles, thus more ApoB containing particles, which we know are most strongly atherogenic. So the CETP protein mediates the transfer of cholesterol and triglyceride among various lipoproteins, and it results in the generation of particles of HDL and LDL, which are of some smaller size. And this smaller HDL gets excreted easily through the kidney in urine, thus lowering the HDL cholesterol levels. And the smaller LDL particles actually are more atherogenic. They can more readily infiltrate the endothelium, undergo oxidation, and damage the arterial wall. Plus, since the particles are smaller, the LDL cholesterol levels also remain relatively lower. So this is the problem of our calculated LDL levels. As you know, most labs, when they give a lipid profile, they do not directly measure the LDL levels. They calculate the total cholesterol, the HDL. They check the triglycerides and then use the Friedewald's formula to calculate the LDL. The problem is this formula isn't valid in patients whose triglycerides are very high, more than 400 or so, or who have impaired glucose tolerance like diabetes or pre-diabetes or metabolic syndrome. Unfortunately, if we look at our population, nearly half the population is suffering from these disease elements. For instance, high triglycerides or metabolic syndrome or diabetes or pre-diabetes. Thus, half of our patients are actually getting a falsely low calculated level of LDL, whereas the true risk will be given to them by checking the direct estimation of LDL level or ApoB particles. So our calculated LDL cholesterol remains low, but ApoB levels or particle numbers often exceed those suggested by LDL cholesterol measurements. Thus, in metabolic syndrome, type 2 diabetes, and high triglyceride levels, ApoB actually reflects the ASCVD risk better due to this mismatch between the LDL particle count and calculated levels. And as nearly 1/3 to 1/2 of the patients in most countries today have diabetes, pre-diabetes, or metabolic syndrome, our risk prediction is poor. And we miss out on the risk which is incurred due to the VLDL particles and remnant cholesterols. That is why increasingly guidelines are now using non-HDL cholesterol, which is basically total cholesterol minus HDL cholesterol, because it includes remnant cholesterol, VLDL, along with LDL cholesterol levels. So LDL calculated levels are being de-emphasized. Non-HDL cholesterol, or better still, ApoB particles, are being emphasized for risk evaluation. And this is reflected in several studies. I'll just show a couple of studies. This is the Copenhagen General Population Study, which showed that the major risk of MI is contributed to by excess ApoB, confirming the role of VLDL. And similar data we found in the Predimed follow-up study, which was published in JACC in 2020, wherein we found that if we look at the subset where LDL is more than 100, but remnant cholesterol is low, the risk is not high compared to LDL less than 100 and remnant cholesterol less than 30. On the other hand, if we look at LDL less than 100 and remnant more than 30, or LDL more than 100 and remnant more than 30, we find that their risk is nearly twice or more than twice as high as the normal lipid subset, thus reinforcing the fact that remnant cholesterol, VLDL particles, and ultimately ApoB particles are most important in predicting atherosclerosis risk. So what is the implication of these findings for our diet? And so I will briefly summarize dietary studies for you. So we have had total 28 randomized controlled trials till 2019 on diet. 11 of these had significant reduction in cholesterol levels, but none of them showed any mortality benefit. 3 diets gave higher fats, and of these, 2 showed mortality benefits. These are Learn Diet Heart Study and the DART Fish trial. Predimed reported 30% reduction in cardiovascular disease with additional extra virgin olive oil and nuts. So these are the 3 studies which actually gave benefits, and all of these had higher fats. The total fat intake, which was earlier recommended by dietary guidelines by Americans, by American Heart Association, was a less than 30% of calorie content per day due to fats. Now we see that this has been turned on its head. In Predimed, 41% of the total calories came from fat. In Leon Diet Heart Study, 40 to 49% came from fat. Saturated fat was also relatively high, being around 9% in both these trials. So this explains the disconnect which has happened between experimental studies and clinical outcomes. But largely what experimental studies have suggested is if we replace saturated fats or carbohydrates with polyunsaturated fats, it has a beneficial effect on health and it brings down the risk of cardiovascular disease. The same relatively less intensity with monounsaturated fatty acids. And if we replace saturated fats with carbohydrates, this results in increasing triglycerides, decreasing HDL and LDL cholesterol levels, and thus the overall effect depends upon the quality of the carbohydrate consumed. If it comes from whole grains, it is beneficial. If it comes from refined starches or sugars, it is not beneficial and actually may be harmful. If it comes from trans fats, it's obviously harmful. But we must understand there is a paradox between diets and drugs because foods are different from drugs, and extrapolating the benefits of lower LDL cholesterol with food does not guarantee the same reduction in cardiovascular disease risk as is achieved with drugs like statins. And we have several failed trials with many lipid lowering drugs which did lower the LDL but did not improve outcomes. Furthermore, benefits which have been observed with foods have never been replicated with nutrients given as drugs. For instance, vitamins and minerals, they are much better when they come with food, and no large trial has ever been shown to give the same benefits when we are given these as drugs or as supplements. So if we now move on to individual foods, we know for the last more than 50 years that there is a serum cholesterol regulation mechanism, and therefore within reasonable limits the amount of cholesterol intake per day has no significant correlation with serum cholesterol levels. So what we find, for instance, is that one large egg has about 188 milligrams of cholesterol. So when an average individual takes this, the amount of cholesterol increase in the serum is only about 2 to 2.5 milligram per deciliter per egg if it is consumed daily. So majority of individuals actually don't have any significant change with the consumption of eggs. A minority, about 1/3, gets an increase in their cholesterol levels, but HDL increases more consistently than LDL, and therefore total cholesterol over HDL ratio and LDL over HDL ratio remain the same. So there is no change with the addition of eggs. Thus, what we find is that LDL cholesterol levels may rise because of the increased size of the LDL particles, which are less likely to promote atherosclerosis. Based on all this data, cholesterol was deemed to no longer be a nutrient of concern in the year 2015 by AHA and Dietary Guidelines of America, and thus the restriction of eggs was removed about 10 years back. So generally now we believe it to be a good source of not just cholesterol, but also rich in complete high quality proteins and fat soluble vitamins. So there are controversies still, but those controversies are largely based on the fact that all the negative studies which have come with eggs come from America. All other studies from Asia, from Europe, from Australia, from Japan, are all positive for eggs. And the largest population-based study, which came from multiple low and medium income countries in 1.77 lakh subjects, actually found that there is no association of egg intake with lipid levels, major CVD events, or mortality. Thus, the American Heart Association recommends one whole egg a day is acceptable in healthy individuals and two in those who are primarily vegetarians. Next, we come to the saturated fat controversy. So what is the problem with saturated fats? They increase LDL cholesterol levels. However, this effect may be offset by the rise in HDL cholesterol, which maintains the total cholesterol over HDL ratio, a decrease in triglyceride levels, and a negligible impact on ApoB. Furthermore, saturated fats are diverse. They may be present in both nutritious foods and in less healthy foods. So they are present in cheese, curd, or butter, but they are also present in fried fruits, oils, nuts, and meats. They are also present in seafood, which is supposed to be very healthy, thus making evaluating fats based solely on their fatty acid profile an imprecise approach. So if we summarize the data on saturated fats, ASCVD, and mortality, 10 meta-analysis of observational studies were done, which evaluated the association of saturated fat with CVD, and they were all negative. 7 of 10 meta-analysis of randomized controlled trials on saturated fats were negative. 3 were positive, but they only reported some lowering of CVD endpoints, no impact on mortality. Furthermore, all 8 meta-analyses which evaluated the association of foods rich in saturated fats with CVD were negative. Dairy fats, again, have been very controversial, but it is now increasingly recognized that actually the intake of curd and cheese, but not milk, are associated with the reduced risk of diabetes and weight loss if replacing carbohydrates. Why? Because fat has a glycemic index of 0. And therefore, when taken with any other meal, will reduce the glycemic index of that meal and thus reduce the risk of diabetes. So there are several meta-analyses which report protective effects of dairy fat and butter on diabetes risk due to this 0 glycemic index and no significant association with coronary artery disease, stroke, or total mortality. Thus, several large meta-analyses have now reported that there is no association of dairy fat with these lifestyle disease concerns, and therefore healthy children and adults may consume low-fat or full-fat milk as per personal choice. Whereas within reasonable amounts, which would mean about 10 to 14 grams per day, 1 tablespoon per day of dairy fat and butter appear to be metabolically safe with possibly protective effects on diabetes risk, but of course keeping in mind the total calorie intake per day. Thus, to summarize the data on fats, healthy fat foods like nuts, extra virgin olive oil, and some dairy fats can be better than processed carbs. Replacing refined carbohydrates and unhealthy saturated fats with unsaturated fats is beneficial. And 3 PUFAs are especially useful, and 6 PUFAs may be useful, but there is little evidence to restrict saturated fats below 6% of daily calories, and thus a diet which focuses on healthy fats is recommended. Furthermore, coming to oils, the healthiest oils are those which are high in monounsaturated fats or PUFA with a high N3 to N6 ratio. In India, we surprisingly have a very low average fat consumption. Our calories of coming from fat per day are only 15% compared to 32% in the West. And the predominant oils we use are actually N6 PUFA rich, like sunflower, safflower, rice bran, other proprietary blends. Saturated fats are generally restricted. Yet we still have growing number of patients with obesity, metabolic syndrome, and CVD. So therefore, we have to now look at the current evidence, which largely supports the consumption of extra virgin olive oil as perhaps being the healthiest oil we have today, and canola oil. Possibly all cold pressed oils are healthy. Healthy proprietary blends, which aim for a healthy mix of MUFA, PUFA, can also be useful, though there are no systematic studies on this. But the dietary guidelines for Indians by National Institute of Nutrition recommends a blend of groundnut or sesame or rice bran oil with mustard or canola or soybean oil with about 20 to 50 grams of visible fat per day, depending upon activity levels. So this could be acceptable since we don't have trials yet, but we should have trials on this. And finally, fried foods should be avoided. Occasional, once a week or less than that, frying may be done in oils with a high smoking point. Though recent data suggests that extra virgin olive oil could be safe even for this, except for very high temperature deep frying. The only issue being the excessive cost, which is why healthy proprietary blends could be the way to go for most normal individuals. Furthermore, trans fats should be completely avoided. And finally, about fat, the emphasis is to be laid on the consumption of healthy fats rather than added oils, as the best outcomes are seen in studies of Mediterranean diets like the Predimed study and the Lyon Diet Heart study. And increasing the percentage of fats in daily calorie intake from 30% to maybe closer than 35-40% may actually be healthy. Proteins are, of course, extremely important. Guidelines have been limiting meat and fat intake, and this has led to the replacement of protein intake by carbohydrate intake. In India, we take about 70 to 75% of our calories from carbohydrates, 15% from fats, and only about 10% from proteins. So this is not healthy. A ratio closer to 15 to 25%, at least 15 to 20%, may be healthier, because proteins have minimal impact on key risk factors. The sources may vary in healthiness, with foods like nuts and fish being beneficial. Unprocessed and processed meats may be harmful. Thus, importance of food type must be reinforced. And finally, proteins are useful in controlling appetite and in preserving muscle during weight loss efforts. Finally, we come to carbohydrates. Carbohydrates make up over 50% of daily calories in most diets. In India, last year's figures show that it is closer to 70 to 75%. So while carbohydrates are generally neutral on cardiometabolic health, refined carbohydrates are linked to obesity, diabetes, heart disease, and even more so in women, older adults, and inactive people. Wheat and wheat products are again a controversial issue. Wheat has amylopectin A, and the protein gluten is quite allergenic. And what is now found is that despite the fact that current wheat does have some amount of indigestible fibers and proteins, what we find is that in practice, the type of flour which comes to us is highly purified and has mostly carbohydrate and nothing else. So it has no longer got the indigestible fiber or protein or fat. So what we find based on scientific studies is that glycemic response to grains is low if we eat them whole or with minimal processing like quinoa, brown rice, or steel-cut oats, as the bran protects the starchy endosperm portion from easy digestion, but the glycemic index is higher if the gram is milled and is highest if the bran and germ are totally removed by processing, as is commonly done, which is why white bread, white rice, etc., and most cereals like cornflakes and highly refined flour actually have a glycemic index which is higher than sugar. So since wheat products are ubiquitous, we can recommend a moderate serving, maybe moderate intake, maybe 2 to 3 servings a day, but not excess. And bread, especially white bread, should be restricted. Coming to coffee and tea, which have also been very controversial, we have some data of J-shaped study, but broadly speaking, what we find is that coffee, when consumed around 2 to 3 cups a day, appears to be healthy, not just for heart disease, but also for liver, also from the brain. And tea is associated with similar benefits, especially when taken around 3-4 cups per day. Thus, the recommendation is to permit the consumption of tea and coffee with some evidence of a benefit of black and green tea in reducing the risk of CVD. So finally, coming to a dietary approach to lipid management, from community health perspective, it is again important to recognize two important types of lipid disorders which we discussed earlier. The isolated high LDL cholesterol variety and the metabolic atherogenic dyslipidemia variety, which is much more common, as these differ in their etiology as well as dietary management. So isolated LDL cholesterol elevation is less common, responds best to restriction of trans and saturated fats and needs drugs for its management. But the much more common metabolic dyslipidemia is managed much better by restriction of total calories, especially sugars, refined carbohydrates, and low-calorie fats, and maintaining an ideal body weight by exercise and lifestyle. So this is the food classification where we divide foods into unprocessed or minimally processed, which are healthiest, culinary ingredients like salt, sugar, etc., processed foods, and ultra processed foods, which are what are being consumed these days. And we believe in the concept of a healthy eating plate, wherein the large bulk should be the vegetables, there should be fruits, there should be healthy proteins, and the carbohydrate intake should come predominantly from vegetables, some fruits, and whole grains, but we should take healthy sources of fats as well. So couple of years back, we published the Cardiology Society of India Clinical Practice Guidelines for Dyslipidemia Management, and I wrote the chapter on dietary guidelines for dyslipidemia in this particular guidelines subset. And we tried to keep it simple. So we tried to give these charts which give us foods about which there is broad consensus that they are healthy. For instance, fresh vegetables, dietary fibers, curd, yogurt, fresh foods, fresh fruits, nuts, seeds, whole grains, fish and fish oil, etc. Foods about which there is general consensus that they are beneficial, and foods about which there is controversy still. And I have tried to discuss those foods about which there is controversy and give you broad outline on what are considered healthy, what are considered unhealthy. So foods considered unhealthy are again divided into those about which there is broad consensus and others about which there are controversies still as to whether they are healthy or unhealthy. I didn't have the time to delve deeply into this because of the limitation of time available. Then we gave some general dietary recommendations wherein we gave the foods which are healthy and can be taken in relatively large amounts, like fresh vegetables, legumes, fresh fruits. Foods which are healthy can be taken in moderate amounts, like nuts and seeds. Whole grains can also be taken, and foods which are high calorie, some of which are healthy and can be taken, but in reasonable amounts. You have to restrict their intake to healthy amounts, but these are fat containing foods and thus they regulate appetite much better than foods which have only carbohydrates. So dairy, fish and seafoods are also healthy and acceptable. We have to see the amount of oils which can be taken, and about 10 gram to 14 gram per day is an acceptable level. Unprocessed meats can be taken. Unprocessed, I'll take just another 2-3 minutes. Unprocessed meats, about 1 to 3 times a meat. Processed meats, less than 1 time a week. We restrict these items like refined grains, hydrogenated oils, sugar sweetened beverages, sodium, eggs and alcohol. Eggs I talked about. Alcohol again restricted less than 1 to 2 small drinks in a day, maybe 2-3 times a week. In males, 1 small drink for females. Tea and coffee can be allowed within reasonable limits. There are controversial foods which need further study, and there is lack of sufficient evidence to draw definitive conclusions about several other recommendations. So those can't be discussed. This includes organic foods, grass-fed versus grain-fed, genetically modified versus non-genetically modified foods. Meats continue to be debated, but recent data shows that the data which showed harm is not excellent. So there is only a low quality evidence that they increase the risk of cardiovascular disease, diabetes, or cancer. So no strong recommendation can be given other than the fact that unprocessed meats may be taken 1 to 2 times a week, but processed meats should be avoided and red meats should be relatively restricted. So the dietary guidelines of Americans have come up recently in 2026, and as you can see, they have largely followed the same dietary pattern which I outlined earlier in the CSI guidelines in 24. So what they recommend is eat the right amount for you, prioritize protein foods at every meals. They have increased the goal to 1.2 to 1.6 grams per kg body weight per day, consume dairy up to 3 servings per day, maintain gut health by eating vegetables, fruits, fermented foods, and high fiber foods, eats vegetables and fruits throughout the day, incorporate healthy fats, mostly unsaturated fats. Saturated fats should be restricted to less than 10%. This is a revision from their earlier 6% guideline for those who are at high risk. Focus on whole grains 2 to 4 servings per day. Limit highly processed foods, sugar, and refined carbohydrates. Limit alcohol and restrict sodium. So several questions remain unanswered, and we shall try and find out the answers to these as we go along. But to conclude, carbohydrates, fats, and proteins are not harmful in themselves. The healthiness depends upon the food choices and their preparation. A plant-based omnivorous diet, which is rich in natural foods, low in salt, meat, sugars, and processed foods, is supported by current data. Balanced diets include fats and carbohydrates without treating them as harmful, reducing the carbohydrate amounts by about 10 to 15%, especially sugars and refined carbohydrates, while adding healthy fats and proteins may be the most beneficial change that one can do. And more local research is needed to determine the best foods and cooking methods for different populations. I'll conclude by saying what Michael Pollan, the respected professor, says about food. Eat real food, not too much, mostly plants. Thank you.
Thank you so much, Dr. Chopra. I think it was an excellent presentation. We will now open the forum for the question answers. Dr. Chong, the chairman, is here. Dr. Chong.
Thank you, Dr. Chopra. This is a topic really that I talk to my patients almost every day. And I think in today's world, we are what we eat. So what are your views on refined carbohydrates boosting, triggering insulin, and then visceral fat, and then all the cytokines from visceral fat, and then causing heart attacks, strokes, and cancer?
Absolutely. I think that is an area which is very close to my mind. As we talked, our intake, especially in Asian countries, is about 70 to 75% of our calories as carbohydrates, which has been shown to be very unhealthy. So they not only increase triglycerides, they increase the secretion of VLDL, thus increasing the ApoB particle number, making the LDL small, dense, and much more atherogenic. And this is responsible not just for metabolic syndrome, obesity, but also cardiovascular disease and cancers. And definitely our focus should be on getting carbohydrates down to about 50% or so of our total calorie content. Maybe a healthy amount is 45 to 50% as outlined in the Lancet study. Maybe going even a bit lower could be okay. For instance, if we look at the Mediterranean diet pattern where the average calories from fat are about 40%, and the average calories coming from proteins are about 20%, carbohydrates probably would come in at around 40%. So I think that would be a more reasonable distribution. The problem is this issue is so controversial and there are so many guidelines that there is not enough data sometimes to back up what one is saying. And, because of the prevailing regulatory environment, you have to be very careful in how you convey things to a patient. So you have to probably give them some data as hard data. Other things we can say based on scientific evidence, based on this is hypothetical. We don't have hard data to support this, but it seems highly logical that what I'm recommending to you may be the right way to go. But please read it up and find out on your own, because these things have become very controversial these days. So that is why one is a bit conservative in what one says, though one is more convinced about whatever you are saying. I agree with you.
Yeah, the Mediterranean diet data was very impressive. I remember reading it, was very, very impressive. The one with the extra virgin olive oil and the small helping of nuts, 30 grams a day. I was quite impressed with that trial. It was an amazing trial.
Absolutely. So basically, the emphasis is on increasing the intake of healthy fats. People have confused the fact that lipids means fats. So they believe that fats in the diet means fats in the heart vessels. So that is not true. And this is something which we have to reinforce. Probably we have to change the terminology. But dietary fats have got confused with fat in the blood. Unfortunately, if we look at the fat in the body and the fat in the blood, what we find is that most of the saturated fat in the body does not come from fat intake, because that fat is actually burned as calories to fuel our activity. The most of the fat which comes in our body is acetic acid, and it actually comes from carbohydrates by direct liver lipogenesis of fat in the liver. So when we don't take fats, our body manufactures fats. Similarly, when we don't take cholesterol in the diet, 99% of the cells in the body manufacture cholesterol. And so they take care of the cholesterol. But if we suppress it with the drugs, obviously it may or may not have certain side effects. So we'll not go into that at the moment. But broadly speaking, our body is a homeostatic organ, is a state of homeostasis. So there are cutoffs everywhere. So there is a balance between manufacture, diet intake, and excretion. So broadly speaking, if we don't disturb it too much, it remains healthy. But we disturb it too much by our current dietary patterns and absolute lack of exercise.
Sorry, Dr. Chopra, I'm going to monopolize you for a little while more.
Okay, sure.
Visceral fat, when you reduce visceral fat, I tell my patients that when you reduce visceral fat by reducing a carbohydrate, for example, I find that the LDL actually comes down quite a bit as well. So is visceral fat correlated to be a driver of LDL?
Visceral fat, I don't think is an absolute driver for LDL, but what happens is all this is correlated. Visceral fat, it is now getting hypothesized that visceral fat presses down on the pancreas and reduces the secretion of insulin.
I see.
So there is
physical.
So there is data now to suggest, you must have seen that recently there are trials showing that if you reduce your body fat if you reduce your body weight by 15%, diabetes can be reversed in 80% of the cases. So why does that happen? That happens because when the visceral fat goes away, evidently the pancreatic secretion of insulin improves. So not only is there an improvement in insulin sensitivity with weight loss, there is actually an improvement in insulin supply as well. And that is why the recent studies have largely been on SGLT2 inhibitors and GLP-1 receptor agonists. So if we look at SGLT2 inhibitors, they are also extremely useful, not just in reducing visceral fat, but they have been shown to reduce epicardial fat as well. So this will lead to reduction in the amount of cytokines that are available, and that plays a havoc with our system and possibly is associated with the lot of acute coronary syndromes which we are seeing in Asia and in India, especially at a younger age. We have an average younger about 9 years compared to the Western world on the time of first heart attack and on the occurrence of heart failure. And this seems to be partly genetic. Indians have a lower secretion of insulin genetically. So there was a large study by CUPS study wherein they concluded that the two Indians, the Pima Indians, are more insulin resistant, and the Indian Indians are actually more insulin deficient. But this may be because we have a higher level of visceral fat and abdominal fat at every body weight and at every BMI compared to the Western world. So the Caucasians have lesser visceral fat at any body weight than we do. And that's why we are more insulin resistant.
Unfortunately, this is also borne out in Singapore's data, where we have the three races. We have the Chinese, the Malay, and the Indian. And our Indian are 7% of the population, but 15% of all heart attacks, unfortunately. Dr. Dawadi has a question.
Yes, please.
Dr. Dawadi?
We can't hear you. You are muted.
Can you unmute yourself?
Can you hear me?
Oh, yes. Yes, now.
Yeah, thank you. Thank you, Dr. Arun. Excellent presentation. And every patient, they are concerned with the food. Before telling their problem, they start, doctor, what to eat and what not to eat. So basically, the rural area of Nepal, UP, Bihar, they have fixed kind of diet. They don't have a processed or unprocessed, saturated, unsaturated. They don't have an option. So they come to us and ask, doctor, what to eat. So they say, we do have chicken. So shall I eat egg? How much egg? And shall I remove the yolk, or shall I eat the yellow part or not? And they use mustard oil. They don't have a extra virgin oil, olive oil, and we can't tell them to buy and eat that one.
Cost is a big issue. See, if people will ask you what they should eat, and the thing we start with are fresh vegetables and fruits. They are the healthiest, followed by legumes, dals, for instance, if you have them. Then salads of every sort. All these are healthy, and they can be had in nearly unrestricted amounts. After that comes nuts, seeds, eggs. Eggs are healthy. If you can have them, you can have one whole egg a day if you have non-vegetarian food, up to 2 whole eggs a day if you are otherwise predominantly vegetarian. Then seafood is healthy. Chicken and meats, couple of times a week or more. Unprocessed meats, not processed meats. So processed meats like salami, like pizza, like salted meats, they are not healthy. They should be avoided. Then we come to dairy fats. Dairy fats are generally good. Milk, some people don't tolerate, but usually people tolerate curd and cheese very well. They have healthy fats, and if you can have them, they are excellent. About oils, the healthiest oil seems to be extra virgin olive oil. I can only talk about data, but as I mentioned earlier, it's prohibitively expensive for most populations. So in India, a lot of proprietary blends are available, which try to give a healthy ratio of MUFA, POFA, and saturated fats. You can use those. Those are cheaper. Mustard oil is also reasonably healthy. Mustard oil doesn't have major concerns. There is not much difference between canola oil and mustard oil, and canola oil appears to be the second best oil after extra virgin olive oil. So mustard oil is okay. If you have a good quality mustard oil, that is fine. It is also good for frying because it doesn't get denatured at high temperatures. So desi ghee is also good. Desi ghee or butter is also good for frying. These two oils are the most stable at high temperatures. So whereas you should restrict frying, frying should not commonly be done. Fried foods should be avoided. You should take them less than once a week. But if you take them, then these are two good cooking mediums in which you can cook them. Desi ghee or butter and mustard oil. These are
Dr. Chopra, why is mustard oil banned in US? I believe there is a high content of
there was a study which showed that there is a risk of cardiomyopathy. That was an animal trial. There is no human trial. And on the basis of that study, mustard oil was banned in the US. But there is only very minor difference between mustard oil and canola oil. Largely, their fat profile is similar. And that is why canola oil being the second best oil after extra virgin olive oil, I believe that we can consume mustard oil. There is no human study showing that mustard oil is harmful.
Prof.
Sir,
Ashraf?
one question. Sir,
Prof.
one more
Ashraf?
question.
Yes, Dr. Dawadi, yes, finish up.
Yeah, one more question, sir. So we have some communities staying in the mountains, so they love pork meat with a heavy fat layer. So generally, I don't have a research on it, but they consume it because they want to keep their body warm.
Right.
So shall I tell them to avoid or take it?
See, the general guideline about this is taking red meats less than once a week. But if you look at the NutriRex consortium report, which came out 2-3 years back, what they reported was that the data which correlates red meats with CVD, diabetes, and cancers is actually very weak. So you can ask people to continue what they are taking while preserving the rest of the healthy lifestyle. Things that will tell you are going in the right direction are your body weight, and broadly speaking, your lipid profiles, your sugar levels, your renal functions, your uric acid. So if your hemoglobin, so if these things are healthy, generally I think you can continue with what they are eating. But I can't write this down and tell you because people will be after my life, because there is no data scientific guideline to back up what I'm saying. But what I'm telling you is based on some science, some hypothesis, and some real life experiences.
Thank
And
you.
one more last question. Last question, sir. So in
Yes.
mountain, the people, they carry 100 and 200 kgs of weight and they climb mountains.
Sure.
And to keep their energy, they take a bulk of rice twice a day, even thrice a day.
Your
At least a
voice
kg of
isn't
rice.
entirely clear, but lifting weights and climbing is a sign of good health. So I don't think that should be a problem.
Yeah.
Exercise must be reinforced.
To take a rice 3 times a day, not a bad.
Again, see, not all things have been tried out, but what we find is that between wheat and rice, rice may be healthier, especially if it is brown rice. Polished rice is less healthy. If it is brown rice, unpolished rice, that is healthier than wheat, though all carbohydrates should be restricted to about half or somewhat less than half of total calories. Half of the total calories should come from proteins and fats. This is my broad belief.
Thank you so much, sir. Thank you.
Thank you. Prof. Ashraf, you have a question? Prof. Ashraf? What happened to Prof. Ashraf? If not, then Dr. Pukari? Oh, Prof. Ashraf, yes. You have a question, Prof?
I have a simple question. I was expecting that Dr. Chopra will be talking about something about
Yes,
can you listen me? Yeah,
Yes,
we can hear you.
yeah. Thank you. So there was a call inside, so that was the problem. Anyhow, thank you very much. Sorry for disturbance. I was expecting that Dr. Chopra must be talking about as being a Punjabi, and he didn't mention. Indeed,
Yes, please.
food is very much important. But one thing for the obesity, for the cardiac issue, and the diabetes, one thing very important for us, particularly about our countries, that is the socio-economic impact on heart attack, what we have. So I think that is the main factor. That is one of the main factors, one can say. Indeed, all these aspects what you have talked. So thank you very much, Arun Chopra. It is a pleasure to listening all that. And I would like if you say a few words about this socio-economic and our all these depressions and anxiety what we are facing. Thank you indeed.
Right. Professor Ashraf, well taken. Lassi comes in two forms. I didn't go into details, but lassi comes in two broad forms. One is the thin lassi, which is buttermilk, so to say. That is extremely healthy, and you can take it as it is, or you can add a small amount of salt in it if you want, but it is relatively quite healthy. And that is what whey predominantly comes from. The whey protein which we find in the market is taken from this. The other type of lassi is the one which we have in Amritsar, for which Amritsar is famous. That is the sugary lassi. That is the lassi which is loaded with sugar and with malai, cream. So that lassi is not so healthy. So that is why we sometimes don't mention it, because lassi in Amritsar is taken to be this buttery, creamy, very high sugar lassi. But the buttermilk which you talk about is very healthy, and that can be taken, and rather that should be consumed. I take it on most days.
Dr. Bukhari, you have a
Thank you very
question?
much.
Thank you
Thanks,
so
Prof.
much. Thank you so much, Professor Bukhari, speaking from Pakistan, from Lahore, very close to you.
Good morning.
Really, and it was a really nice presentation, and so many things you cleared about our desi ghee and makhan, lassi, everything. But I think one of my question, another my suggestion is that along with the nutrition, I am a pathologist basically, what you have told, because these are correlations I do in pathology. But
Right.
according to the data, no doubt the nutrition is very important, but the lifestyle is very, very important. If we have not changed our lifestyle, if
Agreed.
so many things we can do, reduce the fat, sugar, other things. And if our exercise, like our sleeping pattern, like our time of food, and like duration of the food is very important. So if we want to reduce these all issues, so we have to advise our patients and the things that you should adopt the lifestyle, to change the lifestyle. As a Pakistani, daily, when I was a child, I used to see my father get up early in the morning and used to go in the field and something else. So he was 95 years old. And the second thing is that it is not my question, that the suggestion is the intermittent fasting is very, very important. Not only reducing the coronary heart disease, but also the fat and the obesity. Thank you so much once again. Thank you so much, Saurabh, and thank you so much for giving me the time.
Dr. Bukhari, thanks a lot for your comments. And lifestyle is extremely important. My topic today was diet, so I confined it to diet, but exercise is extremely important in good health. And I myself do it regularly, and I recommend it to all my patients, and no doubts about that. So the other thing which you were saying was
intermittent fasting.
Yes, intermittent fasting. That is a bit controversial. That's why I didn't mention it. I myself believe that it is healthy. There are a lot of studies now coming up, it's healthy, but there is an analysis last year which reported that there is some increase in mortality with intermittent fasting. That's why I didn't mention it. But if you think what I think, like I told you, I can't write it down on a piece of paper and stamp it, but this is my view, that intermittent fasting is generally healthy and is useful if you wish to restrict your calories, because you are restricting the time in which you are eating, and further you are improving your insulin sensitivity. Since you are not taking food for maybe 12 to 14 hours a day or more, you are improving your insulin sensitivity. You are reducing the net amount of insulin in your body. This will reduce the risk of not just diabetes, but other metabolic diseases as well. Exercise also improves insulin sensitivity and is extremely useful in combination with intermittent fasting. but I didn't go into the complexities. For that, you need much more time. You need a whole day to discuss all these issues. And if you want a discussion on intermittent fasting or on
Thank you
types
so
of
much.
diet, we can have that. But
Thank you.
not the
Invite
time
you
for
only
that.
for that topic. I think that's a good topic for the next time. We will invite you
Yes,
for that.
yes, you can invite me for that, but today I have to
Yeah.
move. I have
Absolutely.
work waiting for me in the hospital, so I have to move.
Dr. Monica, would you like to say something?
Yes.
Dr. Chopra, thank you again for a fantastic presentation. If I could sum it up in one sentence that you said, just to sum up what our take-home point is, fat has a 0 glycemic index. I think I'd like to end with that. So thank you very much for your time. I really appreciate what you shared with us today.
I think the last message should be the message by Professor Michael Pollan. Eat real food.
Yes.
Means
Thank you,
not too
Dr.
much.
Chopra. Thank you,
Most
and
too much.
most welcome for a great talk. I enjoyed it very much. It's something up my alley too. I really enjoyed today's talk, and you can see from the response from our audience. Thank you very much, and we look forward to seeing you for the intermittent fasting talk.
Okay, great. Thanks. Bye.